let's see, in the past century when I started intensive care, and about half of you were not born at that time, the ARDS was the fundament of our specialty, because intensive care really born with ARDS, because this kind of patient before were not observed because they died before. So the mechanical ventilation, ARDS, are two aspects of the same reality. Sometimes I think that what we call now ventilator-induced lung injury is just an inherent aspect of ARDS, which cannot exist without this ventilation-induced lung injury. But this is another topic. Now, this was the picture. White lung, explosion of the lung after 3 days because of tidal volume. The people wanted the normal CO2, so the tidal volume up to 1 liter was used in these patients, and was also suggested the use of preventive tubes before the mechanical ventilation. Because, because the people say, okay, what is the normal PCO2? 40. So to have 40, this patient, we have to use a terrible ventilation. Terrible ventilation means explosion. But the people was concentrated not on the mechanics, was afraid about FiO2. Because at that time, the devil was the FiO2. And now, what you have learned with RDS, this is what I should cover in 30 minutes. Inhomogeneity of RDS, baby lung, mechanism of composition, mechanism of PIP, pleural pressure gradient, tidal volume distribution, recruitment, the recruitment curve, opening pressure distribution, lung recruitability, anatomic framework for VILI, stress risers, challenge the open lung, mechanical power. All this has been associated to some intellectual or understanding advance due to the image. And before going from the X-rays I showed before to the CT scan was about 15 years, for one simple reason, that the radiologists say, well, you do ARDS CT for what? You have a white lung, is an uniform alteration of the lung parenchyma, so it's dangerous to take these patients, and the CT scan were very slow at that time and were overbooked. Personally, we start with this. Under the input of a dysternia who was doing in ponies, in little horses, CT scan during anesthesia. So we wanted to see what's happened in our RDS patient, because all our patient was in anesthesia and paralyzed. So I told some friends many times, on a Friday night, when the 2 doctors and 2 nurses and 1 technician of the X-rays machine, no radiologist, we got the key of the CT scan room, and we moved with the patient over the CT, paying the radiology technician 50,000 liras, 100 liras in black money, because of course no invoice. But it's difficult to me to communicate what was the sensation at the time when you see something like that. Black and white, black and white, black and white. Because we did not expect that. Now, for you, it is absolutely normal to see something like that. Would be disturbing to see something different, the white up and the black down. But at that time, really, this changed 15 years of copy and paste, copy and paste, copy and paste. The lungs in RDS are white, are the RDS diffuse disease, blah, 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 blah. And the CT scan tell, well, wait a second, there is something different. And look here, this is the PEEP, no response. Here, big PEEP response. Look here the size of the heart. Here the heart becomes smaller, here the heart remains the same. So in these 2 slides, pleural pressure, lung-heart interaction, transpulmonary pressure, recruitability, yes or not, are all concentrated in these 2 slides. And this was 1985. And after decades, you're still discussing some of this problem, which at least the problem was clearly defined here. We did not understand at the time all this problem. Our reaction was, my God, it's just an open lung and a closed lung, white. But white, what means white? So our fortune was not to have the radiologist, because the radiologists like to describe the structure, the morphology. We wanted to see the numbers. So we start to work with the engineer of the hospital. How works this damn machine? Well, it works with density. Density, you may remind, is mass divide volume. And the mass is whatever solid or liquid is in the lung, and the volume is the mass plus the gas. And so having the mass, having the CT density, and measuring at the time with the helium, the gas, we could have in vivo the anatomy of the lung. So how much is the good lung? Is this little part here. And we call, because it was small, we call baby lung. And this explains something. Why the baby lung, why the lung is so fragile? Because it's small. If you use very large tidal volume, you can break it. But, so we start for months to try having the anatomy. We start to try to find the correspondence between anatomy and the physiological parameters that we were measuring, as the space, as the blood gases, and overall about the compliance. And so we expect more disease at this lung. That means greater is this mountain, worse will be the compliance. And it was not correlated at all. And it took months to arrive to the very simple conclusion that when I measure compliance, I measure the open lung, not the closed lung. And so the compliance in one rat is smaller than the compliance in an elephant. And the compliance is a function primarily of the lung dimension. And I think at that time this was the greatest achievement, that the baby lung had an intrinsic normal elasticity. And still now this concept is not passed through. The compliance tell you how small is the lung, not how stiff. The lung, the specific compliance of the lung is still normal. Now, but having the baby lung here, what we were doing, we were taking the patient, going in intensive care and put in position. Because we expected the baby lung were better perfused in prone position. And then another things happens, and my young co-worker was Fumagalli at that time, was at the CT scan with the patient, called me, well, we have a patient, can I take a CT scan in prone position just to show that you are very smart, because the PO2 went up. No? And I said, okay, took it. And he called me after 5 minutes and he said, calm down, there's some problem here. The baby lung disappeared. Oh my God. And you know, it's a sufferance when you marry one idea, and maybe you build on this idea something and so on, and then sometimes happen that must change your idea. And this is a continuous effort in our field. Not marry any dogma. Doubt of everything. I saw that many times in my life. And the baby lung disappearance in terms of anatomy was a good example. Because now I open here and I close there. And still the patient see, well, the great recruitability with the prone position. Wait a second, you recruit one part, they recruit another part. The final depends on the balance. So it's not greater recruit and lower recruit. It's question of measuring what you are doing. And let's see, the next one. Mass means weight. And to explain the disappearance of the baby lung, we come out with, this was a very interesting study. We look at the patients taking the CT at, you can imagine an ethical reviewer now, an ethical committee now, impossible, but one slice, 0, 2, 4, 6, 8, 10, 12, 14, 16, 18, 20 centimeters of PEEP and expiration. And what we found, that in the upper lung, you start to increase the PEEP and expiration, and the gas content goes up. In some slice or in some part, nothing happened, consolidation, and in some part, nothing happened until certain level of PEEP, and then start to increase. And this level of PEEP were related to the compressive forces on the lung. So it came out a very simple model, which is the sponge model. You compress, and of course, if you want to use PEEP and keep open, you have to overcome the compressive forces. If you put in prone position, you compress one part, decompress the other one, and it's very simple mechanics. And then at the time we are at the end of the 90s, so we start with the problem of the atelect trauma. And this is a very early paper. We found that even at 20 of PEEP, some part of the lung, of the recruitable lung, make gymnastic, is the yellow. If you want everything red, that means everything open, you have to use 25 of PEEP. The CT just tell you not what is right or what is wrong. Tell you, look, if you want an open lung, you need 25 of PEEP. Great. 25 of PEEP, unfortunately, correspond more or less to the total lung capacity. Now try to inflate yourself as the beef in Aesop's tales and try to breathe on. And this is the high PEEP. And we had some Taliban view of the high PEEP and the opening the lung and open the last alveolus possible for years. Distribution of tidal volume, opening pressure. The myth was that all the recruitment happens here. Here everything is okay, here is the overdistension, which is not true. These are dogs, inflation and recruitability. Of course, here are modern with high recruitability. These were American dogs. These were Italian patients, exactly the same thing. So we have the opening pressure. Most of the opening happens to here. And then we have some which may open at higher pressure. But the price to pay to keep open 1% of the lung may be excessive for all the rest of the lung. And we never have to forget that within the lung we have the poor heart, which has to pump blood in these conditions. So, and then we have the recruitability. And the PEEP is a sort of holy grail, the best PEEP. The best PEEP, just a beautiful title of my friend Suter in a paper, does not exist. Exists positive and expiratory pressure, but not exist the ideal PEEP, because it is a compromise. Here, on a series of patients, we did not expect that. We did not expect to see a so big, huge distribution of recruitability. Some patients were recruiting almost 40%. Some patients were not recruiting at all. And with the recruitment, we had a lot of discussion with several friends about how to judge, how to measure the recruitment. And so we have the tomography, we had the ultrasound, we have the changing mechanics and so on. To me, the gold standard, it depends how you define the recruitment. Recruitment means to move from one status to another status. If the recruitment is the status without gas, with gas, the CT is the only man that tell you this. If in recruitment you mean, okay, from a little bit gas with more gas, we have a lot of other systems. But with the recruitability, we learned how is wide this world. And then the CT scan told us something about the stress riser. And now we are a little bit something a little bit more complicated. Because the lung is not homogeneous. Homogeneous means the same structure and the same response to a given insult. It's not. Look as an example here. This is the visceral pleura. And we have all the alveoli are connected here. Now, the elasticity of this pleura is about 1/3 of the elasticity here down. When we apply the force, we have a non-equilibrium of force distribution, and we have concentration of forces at the interface. And with a CT scan, we start to measure how much is this inhomogeneity, saying, if I am perfectly homogeneous, I examine all my images. The neighbor of this unit, if it's homogeneous, will be inflated the same way at the same pressure. So if you pass all the units of the lung and you look how much is the inflation in neighbor units, and of course you will have some normal distribution, and what we found is very simple. What's happened here? So let me go to the next, okay. This one. And this is a work which I think has never been quoted, maybe 2 or 3 times, but to me represent the best representation of what we call ARDS, and tell you how is absolutely a wishful dream to try to find a similar therapy, similar PEEP for a situation like this. Why? This is a combination of homogeneity measured with a CT scan is in red. You may imagine, or may accept, or you may not accept, it's no problem, that the pressure when it's red, the applied transpulmonary pressure, is multiplied more or less by 2. This is the order of magnitude. So if I apply 10 of transpulmonary pressure, is 20. If I apply 20, it's 40. And the limit of transpulmonary pressure is around 20, 25, the dangerous limit. White means normal lung, homogeneous, no inflammation, because the inflammation here is looked with the PET scan. So this is the moderate ARDS. Tell me, the moderate ARDS is ARDS. You have 3/4 of the lung which is normal. Where is the problem? How can we put this patient in trials together with this patient? This is severe ARDS. This black means collapsed, red means non-homogeneous, white means inflamed and homogeneous. That means or inflamed or homogeneous. So we have now the possibility to quantitate really the anatomy in vivo. But you know how much is difficult to try to discriminate all these patients. You have to measure to try to characterize each of one, while the tendency is to try to find the magic pill, the magic number, the magic Winnie, the magic here, the magic there, which simply does not exist. And this, always with the CT scan, is opening and closing. Here, this amount is the amount of tissue made gymnastic, opening and closing. At 15 of people, you have the same. Opening and closing is more or less, is a little bit less, but it's not abolished at all. So is atelect trauma so important? The price we have to pay to use a very high PEEP is so important. And this is the transpulmonary pressure and recruitability in patients with mild, moderate, and severe ARDS. We have different words. Recruitment, mechanics, mechanical power. Now, please, I saw also in this meeting there is a title, Energy, Driving Pressure versus Mechanical Power. Doesn't make any sense. Mechanical power is nothing else than a title of the book, which include different chapters. The chapters are the pressure, the driving pressure, the volume, the flow, the frequency, and the PEEP. All this in a particular set may kill you the lung, may kill the lung. It depends, but this study showed blah, blah. It depends on the condition has been done. I think what is important is to learn and to understand the basic mechanism behind the reality. As an example, why, at which state of the total volume we start to have something that the lung cannot tolerate? And so you know how it's important to have the complete picture. The complete picture means the volume I start with, the FRC, the total volume I can reach in reasonable pressure, how much of this space is occupied by the volume I have with the PEEP, how fast is my inflation and deflation, and all this require measurement. And require measurement of volumes, pressures, transpulmonary pressure, and so on. And looking, to me was very interesting to see in animals, because I had the occasion in Milan, in my last year in Milan, to have a CT available at edge to do the experiments in the CT room. And you see, you take the normal peaks and you start to ventilate, and you see that the first lesion, you cannot see probably of this distance, are here. Are the little white round button at the pleural, at the visceral pleural, where the stress riser are more present. Then you start big, and then you have this kind. The first lesion you can see only with the CT scan. Second, you start with the lung mechanics. When we have the gas exchange, the PF below 100, all the cow, beef, and so on already escaped since long time. But what is curious that this kind of lesion induced by the mechanical ventilation are fully recruitable. So this is a nose slide. I concluded a couple of one slide again. This I don't remember when we did these slides, but decades ago. I tell you that some part of the lung is normal, which is more or less true. Some is a small airway collapse, which open at the maximum of opening, what is the mode of the opening pressure is around 20 centimeter of water. Then we have the sticky atelectasis, which are without any gas inside, reabsorption atelectasis, that you'll see, be careful with the ultra-protective ventilation or this kind of thing, which are severe hypoventilation, which generate this kind of thing. And then we have part which are consolidated. The problem of the doctors to understand, in my given patient, where they are, how many they are, because the therapy is just a doctor of this one. And I think that after years, when you say PEEP between 7, 15, we have a lot of papers now, a lot of study we did. The benefits of orotrauma, atelectrauma are similar, or the risk, within this level of PEEP. But if we push with crazy thing as to recruitment with 60 of pressures, or a continuous maneuver, to see the PO2 going up for 5 minutes, 10 minutes, and then decay. I think to use in the common sense is still important. I think this paper, to me, you like or you dislike, is quite important. And I think that what has been developed over the years still makes sense. But my suggestion, and I conclude here, is not to study or to apply this schema that make you good doctors. Make you good doctors to understand how this schema has been generated, and make you even better doctor if you doubt of everything you heard, including what I just told you. Thank you for the attention.